My name is Tim Westbrook, and I'm the host of the I Love Being Sober podcast. The purpose of this podcast is to provide educational content to people that are struggling with addiction, parents, spouses, family members, and friends of people that may or may not want to get clean and sober, and anybody that's interested in learning more about what successful recovery looks like. Today, I'm joined by Dr. Michel Sucher. Dr. Sucher graduated from Wayne State University Medical School in 1972. He's practiced medicine in Arizona since 1974. Initially an emergency physician at what is now Honor Health in Scottsdale and addiction medicine for the past 30 plus years. He has served most recently as the Chief Medical Officer of Community Bridges. Currently, he is the Executive Medical Director of the Meadows Behavioral Health in Wickenburg. His experience encompasses virtually all areas of addiction medicine, including outpatient, medical detox, inpatient, and residential treatment. He has also worked in the area of physician health for most regulatory healthcare boards in Arizona. He is a certified medical review officer by the American Society of Addiction Medicine and is certified by the American Board of Addiction Medicine. Dr. Sucher, so good to have you here. Great to see you.
Thanks, Tim. Good to be with you as well today.
Yeah. Okay, so I'm really excited to have you here on the show. You're very well known across the country as the one of the leaders in addiction medicine and one of the top doctors. And as you mentioned in your, as I mentioned in the introduction, you are you essentially oversee the physicians, doctors, airline pilots that are affected by drug addiction and alcoholism as well. So I'm excited to learn more about that as well.
Great. No, it's been a very interesting ride, and it's still going on. So.
I can only imagine. I mean, how and given the current pandemic, it's just like.
Well, I mean, addiction is kind of an equal opportunity, illness, and when we're in the kind of isolation and staying at home setting that we're all sort of forced in now, that's really where this disease thrives. And I think we're already seeing an increase in alcohol and drug use and a need for treatment, because of this pandemic.
Right. It's like addiction is the opposite of human connection. And with the social distancing and with the isolation, it's just like, it's not conducive to somebody that's attempting to stay clean and sober.
Well, right. And, it's chronic progressive illness. And as it gets worse, you peel away the more remote social and community layers and friends and then family, and you end up by yourself. So it's almost like being isolated at home is kind of like a petri dish for growing addiction.
Right. Yeah. You're not wrong. I mean, I've heard so many stories of so many people that were in recovery and they've relapsed, and I've actually, a guy that I sponsored a couple years ago, I spoke with his mother yesterday, and he overdosed and he's dead now. I mean, it's just like, it's so sad what's happening. And as you said, it's a progressive disease. So
well, and it's tragic too, because a lot of people have family members who are ill, whether it's with addiction, COVID, or other illnesses, and they can't even connect or be directly supportive, which induces all the guilt and shame and fear that also feeds addiction. So
right. So let's start. Before we really get into it, I'd like to hear kind of a little bit more about your journey and what led you to working with people in the addiction field.
Sure. Well, as you mentioned earlier, I started originally in Arizona with my career as an emergency physician in Scottsdale. And I spent about 20 years working in the emergency department which was really a fun and exciting job. And kind of as that career progressed, I began to see more and more people that ended up in the emergency department with alcohol and drug related types of problems, whether those were overdoses, psychotic episodes, medical complications of addiction. And I realized that a lot of the work we do in the emergency room is kind of like putting a finger in a dike, to temporarily sustain something. And kind of a good example would be the spouse who's drunk and punches out his other spouse who ends up in the emergency room. And yeah, I could sew up the cut and split the fractures, but I couldn't really do anything about the underlying problem. And so that plus knowing there were certain things I could only go to a certain length to help in the emergency department, plus I have a long family history of addictive disease in my family, and which I've had to deal with, not only growing up, but as an adult in terms of helping and sometimes being helpless in dealing with them. And those two things, plus friends who were in the field, fostered my interest in pursuing that. And fortunately, as a physician, I was able to literally, over a period of years, change specialties.
Right. And so when did you go from being an emergency room doctor into, like, how did that transition happen?
Well, it probably transitioned over about a 6 or 7 year period. In the late 1980s is when I became really interested in addiction medicine. Found out that there was a society that, by my experiences in the emergency department and my certification in emergency medicine, allowed me to train and take their certification exam early on. And as I started to work, originally it was working and creating physician health committees for what's now Honor Health, but Scottsdale Healthcare, Osborne, and Shea, and to help medical staff members who had behavioral or addictive type problems. And that, at some point, it was new. At the time, I was also working for Rural Metro Ambulance part-time. And this is kind of when Ronald Reagan had started his war on drugs and broad based drug testing for, airline workers, railway workers, Coast Guard. And so fire departments, which Rural Metro was, started looking at that. So I helped them develop their first drug testing program for firefighters and paramedics. And so as that happened, I gradually got to know people at the medical board who asked me to help them, actually through a colleague of mine who was doing that work, but was moving on to another job. And so by the end of 1994, which is when I left the emergency department, I was already moving into more and more work in the addiction field.
Okay. And so you've been involved for a long time with addiction medicine. You've seen a lot. You've seen, I would imagine you've seen what works, you've seen what doesn't work. And so I guess one of the purposes of this interview is I want to find out from you, like, what works?
Well, in a simple sense, treatment works.
Okay.
Without a doubt. But when I started doing this, it was very interesting because years before, decades before, medicine in general and psychiatry in particular, they didn't understand addiction. They didn't know how to help people with addiction. They didn't have any of the typical tools and medications and treatments that they had for things like heart disease, hypertension, cancer, and the like. And so they'd sort of abandoned the field. And really, people who were sort of pioneers in recovery, mostly through their own recovery and through programs like Alcoholics Anonymous and Narcotics Anonymous, really built the foundation of the treatment industry probably in the 1970s and 80s, with the 28-day model, which insurance paid for. And it was very kind of psychosocially based, if you will, and used a lot of 12-step programs that was based on pure abstinence. But gradually, what's happened over the years is two things. One, addiction has become really more recognized and accepted as a true chronic illness, not as a character failing or a moral failing or bad willpower or being a bad person, which has been the stigma attached to this for centuries, not even decades, but centuries. And as that started to occur, we also had pharmaceutical companies coming up with medications that could help people with addiction. The two drugs that really have been around since the 1950s and 1960s, methadone for opioid use and abuse for alcohol addiction or alcoholism, were really also stigmatized. There was a big stigma to being on antabuse, or a big stigma to going to the methadone clinic at 5 in the morning on your way to work or school. And that was for other people. It wasn't for the rest of us. But, you know, things like, and I spent a year as the medical director of the behavioral health system for the state of Arizona through the Department of Health. And that was in the 2005, 2006 arena, which was, if you remember, the height of the methamphetamine epidemic. And, you know, historically, the vast majority of people with substance use disorders are based with alcohol primarily, and maybe opioids secondarily. Methamphetamine was just a little piece. Well, at the peak, methamphetamine represented a third of all admissions into the public sector behavioral health system for addictions, which was astounding. And as you know, methamphetamine destroys your life in all ways more quickly than virtually any drug. You know, for years, I always said alcohol was the most physically damaging drug. Nicotine was the most addictive drug. And of course, they're both legal, right? But I'm kind of came around to thinking maybe methamphetamine won in both categories. And if you've ever seen the pictures on faces of methamphetamine, where somebody in a matter of a year or two goes from looking younger than their stated age to looking decades older with their teeth falling out and their skin fading, and just terrible physical and mental effects. And I think that prompted an interest and funding and recognition for a need for more treatment. And then, you know, then we move on to things like the opioid crisis. In my work for Community Bridges, we started seeing an uptick in opioid problems probably 5 to 7 years before the rest of the world caught on that there was really a opioid crisis. We created a program, I'm thinking this is back 10 years ago, called Unscript, with the tagline, "When the prescription becomes the problem." Because we started seeing prescription drug addicts who then moved on to heroin when they couldn't get the prescription drugs. And when we started that program, everybody go like, "What are you talking about? There's nothing going on here." And of course, now they're beating a path to our door. But for so long, they didn't really recognize what was happening.
So you talk about that. So what did you see? Like, how did the methamphetamine crisis, how did that ramp up and peak in 2005, and then it dissipated? Like, what was that like?
Well, we created and others created methamphetamine centers of excellence, programs based with contingency management, motivational interviewing, ways to try and help people. And I think, quite frankly, by the time it got to the 2008, 2009, I think either they had died off or had gotten better or moved on to a different group of drugs. Right. Now, interestingly enough, as we're really tackling the opioid epidemic, methamphetamine is making a big comeback. And of course, methamphetamine is still very popular in the gay population. You know, so it's really starting to ramp up again.
Okay, and then as the opioid crisis has, or the opioid epidemic has ramped up, like how, from your point of view or from your perspective, what's that been like to watch that ramp up and come to a head?
Well, you know, it's very interesting. Again, methadone, which was really the only treatment available for opioids from a medication perspective, was still very highly stigmatized and very restricted with lots of rules around opioid treatment programs. And then the Drug Abuse and Treatment Act in 2000 created buprenorphine, Suboxone being the most well-known brand, but lots of brands, available as another alternative for treating opioids, particularly in an office-based setting with more confidentiality and more convenience, if you will, to the patient. Because going to a methadone clinic, you have to show up every morning between like 4:30 and noon or so and stand in line and drink your cup of methadone. Whereas you could get a prescription now for a buprenorphine product that might be good for 30 days once you were at a stable dose. Now, initially, it didn't take off very quickly, but I remember participating in a group in Washington, D.C., looking at how this Drug Abuse and Treatment Act was going to be implemented and what the kind of the need was. And at the time, the federal government, and this is maybe around 2000, felt that there were about 1 million opioid addicts in the United States. And at the time, about 200,000 were in opioid treatment or methadone programs. And they considered that 800,000 population to be the, quote, treatment gap. Now, at that time, naltrexone was available as an opioid blocker orally. It wasn't available as an injection as it is now. And really, the federal government didn't consider abstinence as a treatment method for opioids. So buprenorphine was designed to fill in that 800,000 treatment gap. Well, I will tell you, first of all, by the way, when you talk about denial, and denial is obviously denial and minimization are universal findings in individuals with addiction. You know, a person who blames their family, their job, their kids, when the real problem is they're using. But denial isn't limited to the individual or even family members. It works, denial is around in employers, denial is around at the federal government, and even at societal level. So the 1 million opioid addicts in 2000 was probably then 2 or 3 million. Today they say there's 2.5 million opioid addicts. You can probably double or triple that.
Right.
Maybe you'll be close to what's out there. But buprenorphine has been spectacularly successful. There are probably over 1 million opioid addicts on buprenorphine. Now, methadone has grown, but probably in the same time frame, gone from about 200,000 to 300,000. But it is becoming more of a mainstream treatment option and more accepted and less stigmatized. And in fact, the pandemic has really loosened up some of the rules around methadone and buprenorphine treatment. The federal rules say that you can't start somebody on buprenorphine until a physician or waivered medical provider sees them in person for the first visit before going to telemedicine. Well, now you can start it on telemedicine. Methadone, which had strict rules for when you were allowed to have take-home doses, has loosened those rules so that, typically it might take 6, 12, 18 months to earn 2 weeks worth of take-home privileges for methadone doses. Now, if you're even in the early phases of methadone treatment, you can get those take-home privileges to limit your exposure to COVID. So now whether some of that will stick after the crisis passes, I don't know. But along with those things, the recognition of addiction really by the medical community as a chronic illness, the availability of pharmaceutical treatments as part of, because medications alone are not adequate treatment for addiction. There has to be that psychosocial component in the form of various types of psychotherapies, self-help or mutual help type meetings. And it really requires behavior change. You aren't going to get better if you change your behavior. And I like to use diabetes as an analogy. If you're diagnosed diabetic and they put you on metformin or insulin, they don't tell you, okay, now you can eat what you want, gain as much weight as you want, don't bother exercising, and you'll be fine. You still have to do those other things. And if you're an addict, you may be on buprenorphine or methadone or one of the anti-craving drugs for alcohol, but you still have to change your behavior. You still have to not drink or use. You have to be healthy. You have to get psychosocial support. You have to not hang around the people that led you or would lead you back into this. You need to identify triggers for use and avoid them as much as possible. I mean, you don't get healed. You don't get struck healed, if you know what I mean.
Yeah, no, you bring up a really good point, and that's one of the things I think that's one of the misconceptions. A lot of times people think they go to treatment for 30, 60, 90 days. They work on their trauma. They heal the wound, and then they think they can go back to their old environment. And the problem with going back to their old environment is that they haven't developed new healthy behaviors to replace their old unhealthy behaviors that led them to treatment in the first place.
Right. Well, when I started doing this, those were called non-chemical coping skills, which I still think is a good description. But at any rate, as all these changes started to occur, and even though I recognized that addiction medicine would become a specialty in the 80s, I think, in more recent years that's happened. And we have the American Society of Addiction Medicine, which had a certification exam, which became more broadly based. They created the American Board of Addiction Medicine. Now, the Board of Preventive Medicine has a certification in addiction medicine. The psychiatry folks realizing that many of their patients with depression, anxiety, bipolar disorder, post-traumatic stress, ADHD, also had substance use disorders, and they were going to lose their patients if they didn't learn how to address that. That resulted in the formation of a subspecialty of psychiatry called addiction psychiatry. And for example, Community Bridges, Honor Health, and I created the first addiction medicine fellowship program in Arizona a few years ago to train physicians specifically in addiction medicine once they'd already been trained, say, in family medicine, internal medicine, psychiatry, or one of the other primary care, emergency medicine type fields. And so, and once we started that, there's now 3 fellowships in Arizona. There's about 60 or 70 of them nationwide, but they're still not producing enough addiction specialists, but at least we're headed in the right direction.
Right. So you mentioned stigma several times, which, it's kind of like there was a stigma, a long time ago when you first started in addiction medicine, and it's, why don't you just stop drinking? Why don't you just stop using? And it's, people didn't have willpower. Those were the misconceptions. And now alcoholism and drug addiction is way more widely accepted because, to your point, there are way more people that are affected by it than is even documented and reported. And so now the stigma has decreased, and so people can more openly come out like, hey, I'm struggling with drugs, I'm struggling with alcohol, I'm struggling with whatever. And then there was a stigma. I got sober in 2011. There was a stigma around methadone and Suboxone and buprenorphine, and that that wasn't part of my story. However, to your point, like, Suboxone's saving lives. I mean, just because it didn't work for me and is not part of my story, talk about kind of the evolution of what happened with, like, why do you think it's more widely accepted today than it used to be?
Well, let me, I tackle that from kind of 2 perspectives, because the stigma you raise about buprenorphine and methadone versus traditional abstinence is still a controversial area in addiction medicine. But, Community Bridges, where I have worked for many years, treats probably the most, the homeless, the indigent, the uninsured population. In my work with physicians and professionals, I've treated and evaluated, actors, entertainers, athletes, airline pilots, physicians, CEOs, and everybody in between. And literally, this disease can impact anybody. And when you look at it from a disease perspective, I have never met a single patient who wanted to be a drug addict or alcoholic. But I also, by the way, have never met a patient who wanted to have high blood pressure, diabetes, heart disease, cancer, or any other chronic medical problem. The reality is, if you got it, you got it. Now, what are you going to do about it? And so I think that's a critical piece. And, you know, especially when I intervene and evaluate physicians and say, doctor, you need to stop practicing medicine today and go directly to treatment. And after they finish swearing at me and threatening to sue me for millions of dollars, they say, well, how long do I have to go away for? And my answer is, you know, I want you to go get 1 day more of treatment than you need, not 1 day less. Because if you get enough treatment, you won't have to go through this again. If you don't get enough treatment, you may be lucky enough to go through it again, or you may not, which would be worse. You'd be in jail, you'd be dead, you'd, you know, have mental health conditions that are untreatable. So, you know, to me, that has really been a helpful tool. And I think people get that because, you know, you can have an appendix attack and you can be out of the hospital and fine in 24 hours where the appendix could rupture and you're there for 2 weeks. If you don't treat a ruptured appendix, you're probably going to die from it. And if you don't adequately treat addiction, you're probably going to die, or even worse, ruin your life and your family's life from it. So I want people to get enough treatment. The other thing that I saw early on with physicians, where we have very strict, accountable, structured monitoring requirements with random drug testing, groups, mandatory self-help attendance, coordinated medical and psychiatric care, that we really watch people for years. And that's really, you know, and they did well. We have 80, 90+% 5-year success rates documented by objective face-to-face meetings, objective drug test data, and so on, which is fabulous. And so what I realized after, you know, working with physicians for a while, which was originally designed to protect the public, to assure the medical board that physicians who had these issues were safe to take care of patients, is that we were really doing disease management. And why shouldn't this type of program, if you will, work for anybody? Because everybody has something they don't want to lose. People always said, well, a doctor will do it because they don't want to lose their medical license. But I've met a lot of people who don't want to lose their kids, lose their spouse, lose their job, lose their money, lose their freedom, or their life. And so there are motivators. And really, it takes a combination of enough primary treatment, whether that's outpatient program, residential program, whatever that is, plus an ongoing recovery program that gives you the support you need. It's just like, again, chronic disease management of diabetes, asthma, high blood pressure, to minimize relapse, minimize complications, and improve the length and quality of somebody's life. And that's why I say treatment works. You know, the work you do with sober living is a critical piece of that. For people post-primary treatment in early months or years of recovery, really often benefit if they don't have a family, a strongly supported family, or a strong local recovery network. Having a sober living for a period of months can really give them the confidence in a safe environment to move on with their life. So grateful for the work that you do. And you, of course, work with a number of organizations I'm affiliated with that we all think quite highly of what you do.
Right.
But
Thank you for that. I appreciate it.
Welcome.
And I think you kind of touch on the length of treatment. I love that you say, I'd rather you stay 1 day too long than leave 1 day too early. And that's the same thing with our sober living homes. I'd rather you stay 1 month too long than leave early. Because if you leave early, and you know, it's kind of like if your arm's not totally healed, and I don't know how good of an analogy this is, but if your arm's not totally, if you have a broken arm and you take the cast off too early and you end up breaking it, like you're starting over.
Right, exactly. No, that's a very good analogy. I wanted to touch on the buprenorphine methadone stigma, if you will.
Okay.
Because that is still an ongoing controversy in addiction medicine. When we treat, historically at least, treating professionals, we were a total abstinence model, meaning that no matter what your drug of choice might have been, you don't get to use alcohol, marijuana, any potentially addicting medication, prescription or illegal. And so when buprenorphine, well, methadone was, had the stigma to start with as a pure agonist, and it's been historically, it's now called medication-assisted treatment, but it used to be called harm reduction. And, addiction's not a one-size-fits-all disease. We now characterize it through the DSM-5, the kind of psychiatric Bible, as mild, moderate, or severe. But the reality is, if people who have a more severe form of the disease typically need more intervention to help them get better. And that if you are taking methadone or buprenorphine under a medically prescribed, medically supervised program, coordinated with other aspects of whatever your healthcare issues are, that's medical treatment. Now, some people may be able to do total abstinence, and we have with opioids, and we have really good statistics on that in the physician health world. I mean, they do really well with total abstinence, and sometimes with naltrexone as an opioid blocker. The 30-day extended release is something we often use for anesthesiologists who want to go back to working in the operating room, where there's literally unlimited quantities of unaccountable narcotics. It'd be like kind of being an alcoholic working in your own bar, where you could take whatever you want off the shelves instead of serving customers. So, and of course, these are drugs that are much more potent than alcohol, not minimizing alcohol's issues. So I think if you look at the individual patient and you look at what their history has been, I've seen many people, for example, who have tried abstinence from opioids and not been able to do it, and yet they can be perfectly stable on buprenorphine or methadone. I probably personally am treating about 50 or 60 buprenorphine patients. And most of them have been with me, probably the shortest is about 2 years. Some of them are up to 9 years. And they are stable, and they have lives, they have families, they have jobs. They're not drinking, they're not smoking pot, they're not using other drugs. Today we have great tools to monitor these things. We not only have really good drug testing, we're a really low-tech specialty. We don't have fancy procedures and gadgets to use on patients, but we have really slick drug testing. And there's almost nothing we can't test for, whether it's for immediate or long-term use, between hair, fingernail, toenail. Toenails can look back 9 to 12 months. And then we also have something called, in Arizona, but most states have something comparable, the Controlled Substance Pharmacy Management Program. So in a matter of seconds, I can tell everything you've been prescribed in the last year or even the last 12 years. It started in 2008. And there's crossover between Arizona and about 20 other states. So if you moved here from Ohio and you're telling me how you haven't abused anything, and I can look at your Ohio pharmacy profile and see whether that's accurate or not. Because it's again denying, denial, under the acronym "Don't even know I am lying." And sometimes it is quite frank.
I've never heard that before, but that's totally true. And I think it's they call that doctor shopping, right?
Well, we can tell that too, because interestingly enough, the pharmacy profile tells not only what drug was prescribed, what dose, what quantity, the pharmacy and date it was filled at, and the doctor or nurse practitioner or physician assistant who prescribed it. So, I mean, I'll give you a good example. I had this dental hygiene student one day who came to see me and wanted to tell me how well she was doing with her methamphetamine addiction. And she had said, I'm sober 6 months, I've got a therapist, I've got a sponsor, I go to counseling. And so I'd run the profile, right? And I said, well, what about this Adderall you're getting? And she looked at me and she goes, how'd you know about that? And I said, well, not only that, it looks like you drove to Tucson to see the doctor and fill the prescription. Where did you go? And she said, oh, I went to an ADD clinic. And I said, really? Do you have ADD? And she said, no, but I knew they'd give me Adderall. And, we also, unfortunately, live in a convenient kind of world. If you want narcotics, go to a pain clinic. You want methadone, go to a methadone clinic. You want Adderall or amphetamine, go to an ADD clinic. If you want testosterone, go to a men's clinic. And if you want pot, go to a medical marijuana clinic. And they will probably give you what you want. And that's a whole other can of worms, if you will. But it's convenient medicine. I mean, you could also, if you want plastic surgery, go get plastic surgery.
If somebody goes to any one of those clinics, it's going to be on that person's profile.
Well, yes and no. If it's prescribed, first of all, methadone from methadone clinics doesn't show up on that pharmacy profile because methadone is dispensed. It's not prescribed.
Okay.
Medical marijuana originally did not show up. But now they have, if you have a medical marijuana card, that becomes part of your pharmacy profile. Testosterone is a controlled drug, so it would show up. So it varies. It's getting better all the time, but it helps break through denial. It helps get people more accurate and more effective treatment.
Right. Which, I mean, really what that speaks to is just the level of accountability and transparency and support is just increasing and getting better. Because to your point earlier, you said an addict doesn't want to be an addict. It's like an alcoholic doesn't want to be an alcoholic. And the more obstacles or, accountability, support, structure for and increase the length of time, like those are the things that are going to increase the chances that a person succeeds at recovery.
Well, exactly. But how many family members do you see? Well, if they love me enough, they'd stop. Or why can't they quit? They're losing their career. And if you really understand the essence of addiction at a very basic level, we talk about it as a brain disease, and an addict's brain is, quote, hijacked. But the real essence of that is, we all have drives, what I call conscious drives: hunger, thirst, sleepiness. But in those cases, you feel thirsty, you feel hungry, you feel tired. The most primitive drive we all have is the drive to breathe. And you don't think, oh, I haven't taken a breath in 5 seconds. I better breathe right now. It's automatic. Mm-hmm. Well, addiction is kind of one notch below that. Your brain is unconsciously, if you're addicted, telling you need alcohol or drugs like you need air. And again, my patients, the bulk of my patients in the physician health side, they're really smart people, executives, lawyers, dentists, physicians. They're smart people. If it was about being smart, I'd have been out of business a long time ago. But if you have an unconscious message telling you need to use alcohol or drugs to stay alive, like you need to breathe every 5 seconds to stay alive, you're going to do that. If I said to you right now, Tim, hey, look, Tim, we're going to take away all your sober living homes if you don't quit breathing right now. Well, that's ridiculous. That's crazy. But the reality is, if you're an addict, that's how it affects you at an unconscious level. And that's why addicted people give up their family, their career, their money, all of these things. Because if I said to you, look, we're going to take all your money away if you don't quit breathing, you're not going to quit breathing. And it's the same thing. So you need to do two things if you're an addict. And you may have heard in AA or other places, once a cucumber becomes a pickle, it can't go back to being a cucumber again. Yeah. And what that implies is that once you cross that line into having addiction, you can't go back to being a normal person again. So if you are in that today, what I would call moderate to severe substance use disorder, you need to first stop using. And then secondly, you need to learn tools to keep that unconscious message that tells you to use in check. And if you've seen, and I'm sure you've seen people who've relapsed, they don't go after, say, a year or 2 or 3 of abstinence to go back to being a social drinker. They go right back to getting in trouble. And I'll give you another example. I like stories. I had this trauma surgeon who, at the time I met with him, had 3 years sobriety. And he had just gotten this training program at the Maricopa Medical Center, and I saw him on a Tuesday. And he called me on Monday morning the next week, and he said, I need to talk to you about what happened over the weekend. And I said, really, what happened? And he said, well, I got together with some friends on Saturday, and the next thing I know, I was drinking. And I go, well, that's not good. He said, yeah, but I got a DUI too. I said, well, now we really need to connect here. And then I talked to his lawyer, and his lawyer said, did he tell you about the 2 felony assault charges against law enforcement? I said, nah, he left that out. What happened? And he said, well, when the police stopped him for the DUI, they asked him to do the field sobriety test. He said, no. They asked him to blow into the breathalyzer. He said, no. They asked him if he would give a blood sample. He said, no. So in Arizona, you may know that law enforcement can get a search warrant to draw your blood, which they did. And when they tried to draw his blood, he tried to beat up the 2 officers who were trying to execute the warrant. And so here's a guy who goes from 3 years of sobriety, first drinking episode, to a DUI and 2 felony assault charges against law enforcement. The frightening part is that's not uncommon. That's not uncommon. The number of people I see who have whatever length of time, they don't pull it off for very long. They get in trouble immediately or nearly immediately. And that's the nature of the beast. The disease continues even while you're sober.
Yeah, once a cucumber becomes a pickle, there's no going back. I mean, you've been in the business forever. I've been working in the business. I've been sober since, for over 9 years, and I've seen it. Like they're never able to go back. They're never able to go back. It always, 100% of the time, it ends bad. It ends bad 100% of the time.
Exactly. And I just had a case in the last couple of weeks of a physician who we monitored a couple of years ago. And apparently he was looking for some help because he had been stressed by COVID. He was in a grocery store, standing in the liquor aisle, bought himself a bottle of wine, and I took a few swigs, and supposedly that's all he did, but he knew he needed to get back on track. Well, that was about May 5th or 6th. On May 13th, he got a DUI. Who knows how much of this is really true and what the full extent of the truth is. But the reality is it's exactly what we were just talking about. You don't go back to pulling it off for very long.
Cunning, baffling, and powerful, as they say.
Indeed.
Yeah.
But the reality is we understand a lot more about how addiction works than we did years or decades ago. And so the cunning, baffling, and powerful makes sense when you understand how it hijacks your brain and creates that false chemical lie, if you will, that tells you need to drink like you need to breathe.
Yeah, I've never heard that before, and I like that. And it's true. You see it. It's like why, and people that are not in recovery and people have never struggled with addiction, they just don't understand it. But that's a really good analogy. It's like like taking a breath. Like if you feel like you take a breath or you're gonna die, guess what? You're gonna breathe, and it doesn't matter who you hurt or what you lose along the way.
Oh, exactly. You can't stop until you get away from it and learn how to keep that in check. It kind of reminds me, I don't know if you ever remember, there was a woman who created, her name was Boynton, Boynton. She wrote greeting cards. And she wrote a book called Chocolate, the Consuming Passion. And in the foreword to the book, she says, when I speak about liking chocolate, I sort of mean like liking breathing. And so, she had this years ago and having nothing to do with the type of addiction we're talking about. By the way, the other thing we didn't touch on this really is that, we've primarily been talking about substance addictions, But there are also what we call process addictions, gambling addiction, sex addiction, there's eating disorders. I mean, there's a host of other things that can really, in a lot of ways, work the same way. And I think, if you're familiar with Dr. Patrick Carnes, who really was the person who coined the term sex addiction, and if you speak to him and look at the research he's done, it's about addiction is about kind of getting away from your feelings and your present. So it's about not being there. And so in some ways, it doesn't matter if you're at the house of prostitution, the bar, the casino, the crack house, you're gone. Or even if you're at work addiction and exercise addiction. I mean, some of them are healthier than others. People reward work addiction. You get more praise and more money, even if it's wrecking your life.
Right.
But that's a whole another discussion too.
Yeah, we could talk for hours. There's so many different, and they all affect your brain in the same way.
Right, and the same part of your brain. And I think it's very well proven about the biological nature of substance addiction. And I think Dr. Carnes has gone a long way regarding sex addiction, which is still, by the way, not a recognized medical condition in the psychiatric Bible. They have other names that aren't as pejorative as addiction, sex addiction. But at any rate, I think these other addictions will really show very much the same type of mechanisms.
Right. So you've worked with in the indigent population, you've worked with doctors, lawyers, airline. I mean, you've worked with CEOs, you've worked with high profile individuals. And does addiction discriminate?
No, it really doesn't discriminate. But one thing I kind of might like to add is, one other reason why there are so many more people getting treatment, because historically the number of people who needed treatment way exceeded the number of people who got treatment. Mm-hmm. So a lot of progress has been made through Medicaid expansion, through the Affordable Care Act, even crises like the opioid crisis, which has made insurers pay for more treatment, as well as treatment becoming more acceptable. No, I think it is an equal opportunity problem. I've always thought that the people who get the best treatment are really the people who are really poor or really rich. The access, Arizona Healthcare Cost Containment System, our brand of Medicaid here in Arizona, is a really robust program and really pays pretty well and is very comprehensive. On the other hand, people who are very wealthy can also, afford to find the most high quality treatment available. But I think that gap is filling in as insurances pay for more services, so that the workers and the commercially insured population is beginning to have easier access to higher quality treatment.
So my, the numbers, like the percentage of people that go to treatment, typically that stay clean and sober for over a year is less than like 10%. I think those are the numbers. And
go ahead. I'm sorry.
I was just going to say, I wanted to compare that to some of the people that are forced to be in the system and monitored for 5 years. Like, let's compare the success rate between those two.
Okay, well, there's a couple of issues to consider. I guess the first thing I would say is there's no uniform definition of success. Okay.
True.
If the physician health program definition of success is full program compliance and abstinence during the 5 years of monitoring, which I think is a pretty good measure, frankly, that's in the 80 to 90+% range at 5 years. But for many, it's did you take the full course of treatment? Did you remain in treatment for 6, 12 or more months? For example, in the opioid treatment world, the definition of success is how long did you stay in treatment? And historically, people on methadone, the percent of people who stay on methadone for a year or more is very high. The percent of people who stay on buprenorphine for a year or more is not as high. But the people who I treat, the 50 or so people I have who've been with me for 2 to 9 years, depending on how long, when they came along, are extraordinary successes, even though they're on buprenorphine or methadone. So I think I don't know if there's ever going to be a uniform definition of success in recovery, but depending on the methodology, or even if you look at, for example, the pharmaceutical studies that led to the approval of buprenorphine for opioid use disorder, or naltrexone injectable for opioid and alcohol use disorders. Those are typically 6-month studies, maybe 9 or 12 months. They're not 5 years. They're not beyond. Even when we look at the physician health outcomes, and airline pilots, by the way, are very similar outcomes. So they have same kind of program and same kind of outcome statistics. What we don't know is, well, how well do they do after the monitoring goes away? And it's not easy to get that kind of data. The premise was that if we monitor you under a very structured, accountable program for 5 years, after that, you will be able to manage this on your own without oversight, that the medical board can feel comfortable you're still safe to practice, and we can feel comfortable you're staying healthy. But we don't know that for certain. I do believe it's probably pretty high. And when you look at the funding streams, the millions of federal and state dollars that are spent on substance abuse treatment, if your number of 10% is right, who's going to spend billions of dollars for a 10% outcome? Nobody. And so again, and not being critical at all, there are different ways to measure success. And some of that might be length in treatment. Some of that might be compliance with the treatment regimen. Some of that might be, and not saying that I totally agree with this, but drinking less or using less or not getting arrested again. I mean, those are all valid measures of progress and success.
If you don't get arrested, if you don't lose your job, if you don't get a DUI, if you don't get divorced.
Well, divorce is a multifaceted issue.
I know. I'm just trying to use some very concrete, yes or no answers.
Well, again, my 50 patients who are 2 to 9 years in recovery, in treatment, on buprenorphine or methadone, they are all successes, in my opinion.
Yeah.
They are all successes, in my opinion. The physicians who get through 5 years of monitoring and don't use and are compliant, they're successes. The definition is different in both cases. And I think that's, there's going to be more learned and more revealed as we learn more about what works, what doesn't work, and about how to identify and treat this disease. Obviously, like any chronic illness, the earlier you diagnose and treat it, the more likely you are to get better and stay better, than somebody who's very late in the disease. If you catch a cancer at stage 1, it's a lot easier to treat than at stage 4. Somebody who's diagnosed as diabetic at 14 years old and gets on a good structured treatment regimen is going to do better than someone who really either didn't follow a treatment plan or wasn't properly diagnosed, and now they're 50 years old and they have to have their foot amputated and they're going blind and their kidneys are failing. Harder to do something for somebody like that. If you medicalize it, everything works. And
follow the treatment plan. The chances it's going to work are pretty good.
Well, exactly. And a lot of it also is, what other health issues do you have, or what other mental health issues do you have? Because the more conditions you suffer from makes treating all of them harder. And if you have severe depression or bipolar disorder, and if you're not taking your medications, you're more likely to end up back in trouble with alcohol or drugs in addition to your disease. And if you're drinking or using drugs while on your medications for those conditions, they're not going to work, or they're not going to work very well. But I one thing stands in my mind that a friend of mine told me, This is, and I got to give him credit for it. His name is Joseph Persh, and he's the addiction psychiatrist who's mostly known for treating Betty Ford herself, for treating President Carter's brother, for treating Buzz Aldrin. And he says that, addiction is the only chronic illness that you can get weller than well from. And what he meant by that was that your life can be better and healthier and more fulfilling because you had addiction and recovered from it than if you'd never had it. And he said, you can't say that about any other chronic medical illness. And I agree with him. And I've seen countless examples of people whose lives have literally been transformed in a positive way because they had this issue, dealt with it, and continued to deal with it. It opened doors they probably never saw as life possibilities.
I've seen that time and time and time again. I mean, I know lots of people in recovery that have been sober for a long, long time who live amazing lives. They're happy, happy, joyous, and free. And you're right. It's kind of like being, addicted to drugs and alcohol. It's like life is miserable. But then once you get on the other side of it and you really learn how to live life and do the next right thing and be of service and take care of yourself, health becomes a priority. Eating good, healthy, nutritious food becomes a priority. All the things with, related for me anyways, taking care of myself, like those are all things that are priorities in my life. And it wasn't like that before I got clean and sober.
Yeah. Well, I mean, exactly. I think, and the other thing is that in addition to the quality of life in terms of family, career, finances, absence of legal and criminal types of problems, being in recovery from substance use disorders probably helps your blood pressure be better, helps your lung disease be better. And of course, let's not forget nicotine and tobacco, which kills way more people than alcohol and all the other drugs added together. That's probably the single biggest health hazard facing individuals in recovery, because there's a very high percentage of people who use nicotine, mostly in the form of cigarettes. And now I'm really quite concerned about this vaping epidemic. And so there's not going to be a shortage of issues to tackle as we move forward.
Right. Well, we're kind of coming up to the end here. Is there anything else that you want to like top 3 suggestions you have for somebody that is, and I think I know the answer, but top suggestions for people that really want to recover from this disease?
Well, yeah, I guess I would say, 1, recovery is possible. 2, treatment works. 3, if you have a problem or you know somebody who has a problem, get help. And there's plenty of help available. And kind of a word to the families. I mean, there's plenty of counseling and therapy support. There's Al-Anon for family members and friends of people with alcohol and drug-related issues. And you aren't helping somebody by covering for them, hiding them out. All that really does is allow the disease to get worse. So, it's, always my advice, get help, get the best help you can possibly get, and as soon as you can possibly get it. And also the family members need help themselves because they've been dealing with difficult situations, and they need to learn how to help themselves to be able to help their affected family member or friend.
Right. And I think that the one last thing that I think you would agree with is continue your support as long as you possibly can. Continue treatment, continue aftercare, stay in it longer than you think you should.
Absolutely. I've never met anybody that got too much help. Seen a lot of people who didn't get enough.
Yep. I can agree with that.
Great.
Michael, Dr. Michel Sucher, thank you so much for your time today. Is there any way that people can reach you if they have any questions for you, or
Oh, sure. Yeah, absolutely. I don't know what the best way, my office number, I'd give you my office phone. If that'd be the most helpful, 480-990-3111 would be the best way to reach me, probably. So.
Okay. Thanks so much. Have an awesome day.
You as well, and an awesome, very unusual, but hopefully great holiday weekend.
Absolutely. Yes, absolutely. Bye now.
Bye-bye.